Good afternoon to all. First, special thanks to my mentor Dr. Bansi Sabu sir, SR Arvind sir, Manoj Chawla sir, and all Diabetes India team for giving me this wonderful opportunity in 12th World Congress of Diabetes India Conference. Now I request to my co-chairperson Dr. Rajesh Desmani sir. He is a consultant diabetologist and metabolic physician at Sri Mahalakshmi Diabetes Institute. Over to you sir and introduce our first speaker of this session. Over to you. Introduce Dr. He is a senior consultant physician and diabetologist at Department of Research and Metabolic Disorders, Mahavir Jaipura Raj. American. Hello, American College of Endocrinology, fellow of Indian College Madras Science Foundation, Diabetes India, fellow of Glasgow and Edinburgh. So he has this awards and orations to his credits. He is also associate editor for International Journal of Diabetes in Developing Countries. Dr. Arvind Gupta sir.
Hello. Thank you, Rajesh. Thank you, Malay, for kind introduction. And at the outset, I also thank Dr. Bansi, my younger brother, Dr. SR Arvind, and whole team of Diabetes India to invite me for this wonderful Diabetes India conference at Goa. Dear friends, what I'll be speaking in next 15 minutes or so regarding just I want to emphasize in front of you that chronic kidney disease and the high CV risk, they are equal. I mean, they are the single disease spectrum, and if you would have there in the morning with Dr. Shashank Joshi's session, he also emphasized the similar things that CKD is equivalent to a cardiovascular risk, and not only CKD but also the diabetes also equivalent to the cardiovascular risk. Nothing special for this. Dear friends, these are the facts. The chronic here we know that it was characterized by a progressive decline in glomerular filtration rate, years resulting in the permanent kidney failure. This was earlier we understood about the chronic kidney disease. But recent KDIGO, which the KDIGO statement, which states clearly the chronic kidney disease is defined as either kidney damage or reduced eGFR less than 60 ml per minute sustained for more than 3 months. This is the typical definition of chronic kidney disease. And what we know also about this chronic kidney disease, but it carries a large burden of comorbid, especially the cardiovascular conditions, than do without chronic kidney disease. And it has a actually additional burden of having congestive heart failure, myocardial infarction, and stroke. So dear friends, if you have a chronic kidney disease, you are having more risk for other comorbid conditions, especially the cardiovascular disease. So it is a vicious circle, and how the vicious circle is that we know that diabetic kidney disease develops in around 40% of patients with diabetes. This is the data, which is very recent data also. And type 2 diabetes, heart failure, and diabetic kidney disease are the major pandemics of this 21st century, and they often coexist. If you see here on the vicious circle, the type 2 diabetes leads to chronic kidney disease as well as the heart failure, and if you have all these phenomena, you have a sodium retention. So ultimately, if these conditions are not being treated or being prevented very early, then there will be permanent kidney damage, permanent sodium retention, and there are so many other complications. And if you see, there is a common thing, if you have a hypertension, if you have a reducing EGFR and proteinuria, ultimately what will happen? The cardiovascular morbidity and mortality will increase if you have all the three risk factors. We know this factor very well, that type 1 diabetes and type 2 diabetes, the chronic kidney disease is common. The diabetes is the real cause for approximately half of all the cases of end-stage kidney disease, and it amplifies. When you have a chronic kidney disease, it amplifies whatever the hidden or imminent cardiovascular risk is there, and it actually amplifies later. And patients with diabetic kidney disease actually ultimately leads to end-stage kidney disease. What are the data suggests to us that cardiovascular outcomes worsens with the chronic. As your chronic kidney disease progression occurs, your cardiovascular outcomes worsens. If you see here, whether the composite endpoints or death from cardiovascular causes or reinfarction, congestive heart failure, stroke or resuscitation, you see here as your EGFR goes and as your EGFR reduces, your cardiovascular outcomes actually increases. Similarly, your cardiovascular mortality risk also increases as your kidney disease progresses. Not only that, but risk of cardiovascular events is greatest when you have both diabetes as well as chronic kidney disease. And here it clearly predicted here that whether it is a congestive heart failure, acute myocardial infarction, stroke, peripheral vascular disease, atherosclerotic vascular disease, or even mortality, when you have diabetes and chronic kidney disease, it amplifies and increases more. So dear friends, mortality risk doubles when you have both type 2 diabetes and chronic kidney disease. And here, I think you have seen this in the morning with Dr. Shashank Joshi's deliberation. Cardiovascular disease in the patients with or without chronic disease, if you see here on the left side, if a patient with chronic kidney disease, and this is the very recent data, that you have cardiovascular congestive heart failure of around 43%, stroke around 26%, and acute myocardial infarction around 15%. But if you do not have chronic kidney disease, probably you have less stroke, around 20%, less congestive heart failure, around 18%, and acute myocardial infarction, around 6.4%. So both risk of MI and all-cause mortality in people with chronic kidney disease with diabetes, if you see the retrospective analysis, clearly it increases. And this is very typical of the EGFR relation with the cardiovascular events. If you see here, as your EGFR reduces, your increased chances of having more cardiovascular events. Similarly, cardiovascular mortality, if you see in the second, that as the EGFR goes down, your cardiovascular mortality increases. Similarly, the renal events are increased when you have a reduced EGFR. So what is the pathogenesis? How they are interrelated? There are several mechanisms, and scientists have evaluated several interrelated mechanisms why the cardiorenal symptoms are there. So if you see here, that it is the basically increased renin-angiotensin system, increased sympathetic nervous system, and reduced EGFR are one of the basic pathophysiology by which you have several other factors. If you combine with anemia, erythrocyte imbalance, electrolyte imbalance, mineral metabolism disorders, uremic toxins, malnutrition and inflammation, they all combine with this increased renal renin-angiotensin system and sympathetic nervous system, and that's why your kidney or renal effects are there. Similarly, in the arterial system, if you see here, there is a vascular resistance developed, left ventricular hypertrophy and left ventricular remodeling occurs, and ultimately it is an endothelial dysfunction leads to the decreased baroreceptor reflex, and hence your arteries are stiffened. So there are interrelated mechanisms. You have the traditional risk factors, like if you are older age, you are having cardiorenal symptoms. You have family history positive, hypertension, diabetes, dyslipidemia, or tobacco use, you are having more prone for cardiorenal symptoms. Similarly, there are certain newer factors like pressure overload, volume overload, RAS activation, or sympathetic activation, or even vitamin D deficiency can also have the more of the cardiorenal symptoms. And certain novel risk factors like endothelial dysfunctions, defects in glycocalyx, reduced bioavailability of nitric oxide, and these are the other inflammatory cytokines which may lead to the cardiorenal symptoms together. Not only this, the major acute cardiovascular events are more when you have a diabetic kidney disease. And this is the capture study. And this capture study clearly suggests to us that cardiovascular disease prevalence increases with age and reducing eGFR. If you see here, they are all shift to right. So there is a definite interaction between cardiovascular disease and chronic kidney disease. I'll not elaborate so many factors here, but there are interrelated several factors and mechanisms by which your arteries are involved, your heart is involved, and your kidneys are involved. So there is an interrelated mechanisms by which your diabetes and chronic kidney disease have common factors like hypertension, atherogenic dyslipidemia, endothelial dysfunctions, and they are, that lead to hypercoagulability and chronic inflammation and oxidative stress, by which your diabetes or hyperglycemia may lead to diabetic kidney disease. And this is a very typical example. If you see here, the coronary artery calcification in a normal coronary arteries, if you see the adventitia and intima, they are very much intact and clear-cut things are there. In a chronic kidney disease related to CAD, what you see, coronary artery without atherosclerotic plaque, but later on, the heavily calcified atherosclerotic plaque you can see when you have a chronic kidney disease. And the extreme right side, non-chronic kidney disease, they also develop the calcified atherosclerotic plaque, but more when you have a chronic kidney disease. So there are several traditional and non-traditional risk factors. We have already seen that. And the prognosis is already there. According to the stage of KDIGO, there are different stages. And according to different stages, you have the cardiovascular risk more. And how to diagnose early detection of the chronic kidney disease in a cardiovascular disease patients. ECG is one of the most important thing. Earliest you do ECG and see if there are left ventricular hypertrophy. I think it is suggestive of the cardiovascular disease. Similarly, you can go for echocardiography, SPECT scans are there, dobutamine stress echocardiography is there, and you can go for even coronary CT angiography, by which you can diagnose very early the cardiovascular disease and how to prevent. That is the important thing why I am here. We know that cardiovascular disease and chronic kidney disease is a single disease spectrum. Hence, our more important duty towards the patient is to prevent as early as possible both chronic kidney disease as well as the cardiovascular disease. So it can be a primary CKD prevention. So you have to identify the risk factors. That is the most important. Identify risk factors earlier, which we have seen the traditional and non-traditional risk factors, and then do something to prevent the chronic kidney disease in a cardiovascular disease. In a secondary prevention, when you have already diseases there, then the detection of CKD very early in the cardiovascular disease patient, then do something. As Dr. Shashank told in the morning, I think everybody was there, that you either start with the SGLT2 inhibitors or mineralocorticoid receptor agonists. These are the drugs you have to start very early if you want to prevent the chronic kidney disease at the secondary prevention level. At the tertiary prevention, of course, there are several complications are already set in, like uremia and fluid overload, and you have to actually treat effectively in that as a tertiary prevention, so that your kidney progression of chronic kidney disease may be slowed down. So how to manage? Statins are the drug of choice if you have a dyslipidemia that may reduce the atherosclerotic cardiovascular disease burden. Aspirin, if it is a secondary prevention, of course it is controversial at the primary level, but at the secondary level, I'll definitely start the aspirin. Other antiplatelet therapies are already available, like GP2B, 3A inhibitors. They are already available, but safety is questionable. So, I mean, depending on the drugs, you have to think of this particular antiplatelet therapies. Some of the interventions are there, and if you have an interventionalist, then you can think of interventions in the management of chronic kidney disease, and of course, detection of clinically significant atherosclerotic cardiovascular disease and effectively manage the atherosclerotic cardiovascular disease. So dear friends, you have actually a dilemma and challenges in front of you when the patient comes to you as a cardiovascular disease and chronic kidney disease, whether it is a stage 1, stage 2, stage 3, and think of primary prevention, secondary prevention, or tertiary prevention according to stages of different chronic kidney disease as well as the cardiovascular disease. Think of cardiorenal interaction, do effective management as early as possible. There are several drugs, and I don't want to talk about the MRAs, Finrenon. The morning it was dealt in details, but little bit about the SGLT2 inhibitors. They are very good drugs, and I think whenever you have an early chronic kidney disease, start SGLT2 inhibitors as early as possible in your patients to either reducing the renal endpoints or the cardiovascular endpoints, MACE and congestive heart failure in your patients of chronic kidney disease with cardiovascular disease. This is a very recent one. I think this is on not 1 month before. This paper has published in the American Journal of Kidney Disease, and this clearly suggests that if you can use very early SGLT2 inhibitors with metformin, not only several risk factors and several complications you can prevent, but also you can treat effectively the chronic kidney disease progression in a cardiovascular disease. Dear friends, so much has to be done in the future regarding epidemiology. We still do not know the exact data of chronic kidney disease in cardiovascular patients. Your presentation of this disease is sometimes very asymptomatic, and you never actually realize that this patient has already set in chronic kidney disease in your patient. So early detection is the key. So presentation, don't go with the typical presentation that patient will come into typical uremia or renal failure. Of course, you have to predict, seeing the different risk factors, you have to predict and do certain tests to see whether patient is already having the chronic kidney disease. Of course, you have to understand, and in the future, we want to know more about the pathophysiology of different interactions, but still we know that oxidative stress, inflammatory cytokines, inflammation itself, fibrosis itself, that may lead to a cardiorenal symptoms. Thank you very much for patience listening.
Thank you. Thank you so much, sir, for your very informative and excellent talk as usual. So now I invite our next speaker, Dr. Abhay Sahu, sir. He did MD Medicine and DM Endocrinology from AIIMS. He is Professor of Endocrinology and Department of Endocrinology and
Metabolism,
Metabolism.
IMS and Vaccine Hospital, Bhubaneswar. He is organizing study of Acetone 2018, Acetone 2012, and Aerotone 2016. He is also co-organizing secretary of Acetone 2014 and 16. He is investigator in 3 ongoing international trials and recipient of the Rajdhani Gaurav Award Odisha in 2016 and Vikramra Sri Award in 2007. He is invited as guest faculty to various national and international conferences, and he has
Thank you, respected chairperson, my dear friends and colleagues. So, after Dr. Arvind Gupta's talk, totally probably it was such a separate thing, but we are going to discuss. This is hypoglycemia associated autonomic failure. So, a lot of the time in our clinical practice, we know that once someone is diabetic, probably in the lifetime, someone has one or more episodes of hypoglycemia, and once there is hypoglycemia, how this hypoglycemia is responsible for autonomic failure and how it influences the management, we'll discuss that part. So once, if you'll discuss hypoglycemia, any episode of abnormally low blood glucose concentration that exposes the individual to potential harm. We know that any sort of significant hypoglycemia is one of the factor which plays a critical role. And how you are going to characterize hypoglycemia? Probably there is classical symptoms, either neurogenic or neuroglycopenic symptoms. And if you are measuring blood glucose, it should be measured in the laboratory. A blood glucose measurement by a glucometer is not advisable during the phase of hypoglycemia. And third most important thing is there occurs resolution of the symptoms of hypoglycemia after giving glucose. So these are the three things which is classically known as Whipple's triad. You will see different trials. We have actually, from the morning, we have seen a lot of discussions about different trials, how actually this, the standard control versus intensive control. The classical three landmark trials, you will see the ACCORD, ADVANCE, and VDAT. The standard control group, you will see the hypoglycemia, it is quite less. But of course, we know, even if in our clinical practice, when you plan to do a tight glycemic control, always we face some sort of hypoglycemia, whether it might be a minor hypoglycemia, it might be sometimes, rarely it could be a major hypoglycemia, but the hypoglycemia incidence significantly increases. So you see the ACCORD, ADVANCE, VDAT, in the intensive harm, it is 5.1 versus 16.2, ADVANCE 1.5 versus 2.7, and VDAT 9.9 versus 21. So everywhere, a tight glycemic control has some sort of effect in hypoglycemia. And the important thing is, the majority time the hypoglycemia is unrecognized by the patient. If someone is having a mild hypoglycemia, many of the episodes are asymptomatic. If you are going a CGMS data, probably you can detect a lot about hypoglycemia. And in one study, you see in 63% of type 1 diabetes and close to 47% of type 2 diabetes patients have unrecognized hypoglycemia when you are measuring in the CGMS. So that shows that a significant number of mild hypoglycemia sometimes is not detectable. And the most important part is 74% of all those hypoglycemia does happen during the night. That is one of the biggest challenges, because we know during the night time when someone is sleeping, some sort of major hypoglycemia is quite detrimental and makes the patient might land up in complete unconsciousness or might land up in the hospital. So what are the, once there is hypoglycemia, what is the response of the body? What are the physiological response? The first response is decrease in insulin, which happens between a blood glucose of 80 to 85 mg/%. And this is considered as the first primary glucose regulatory mechanism, and that occurs, this is the first defense mechanism against hypoglycemia, that is decrease in the insulin. Rest second is increase in the glucagon, which happens between in the range of 65 to 70 mg/%, and that is the first counter-regulatory. It is not regulatory. Glucagon is a counter-regulatory hormone, it increases the blood glucose, whereas the decrease in insulin is the regulatory part for particularly blood glucose. So second defense mechanism is particularly reduction in the increase in the glucagon level. Third defense mechanism is epinephrine, but the epinephrine plays a critical role those who are having glucagon deficiency. That is utmost important. Those who are having glucagon is not there, probably epinephrine is the thing which plays a critical role. And the fourth is increase in the cortisol and growth hormone. They plays a role, but they are not critical. Second important part is that when there occurs blood glucose comes down up to 50 to 55, the first defense mechanism is the appetite significantly increases. Someone will have some significant appetite. If you are taking food at that time, probably that hypoglycemic episode will completely recover. But if still you are not taking anything, food, whether glucose, anything, then patient actually end up in decrease in cognition. Again, there occurs decrease in the brain glucose metabolism, which may lead to unconsciousness and seizure in the subsequent part. So these are the way how during the phase of glucose reduction, how the body behaves. This is the defense mechanism in the body. So what is the basic pathophysiology? If you will see, when there occurs decrease in the blood glucose, in the pancreas there occurs decrease in insulin and increase in the glucagon, and the liver there occurs neoglucogenesis, increase glucose production. Same thing happens in the kidney, neoglucogenesis, increase in the glucose production, and they try to increase the blood glucose level. And what is happening to the brain level? From the brain, sympathetic outflow increases. That sympathetic outflow and from the acts on the pituitary gland, from the pituitary it stimulates the production of growth hormone and cortisol. And all those things increase in the epinephrine, and this growth hormone and cortisol, they try to increase the blood glucose level by specifically neoglucogenesis. And here, these are some of the muscle and fat. There are some of the factors, the lactate, amino acid, and glycerol comes. This lactate, amino acid, and glycerol actually are the neoglucogenetic precursors which is responsible for the production of the glucose in the body. Then this glucose in the CNS, when there occurs a glucose decrease in the glucose, this actually acts on the sympathoadrenal outflow is increased. This sympathoadrenal outflow, all those things acts on the liver, muscle, kidney, and fat. This leads to increased glucose production and decreased glucose clearance, and they try to conserve body or preserve glucose in the body, and this is the way how they defense or give some sort of defense against lowering blood glucose in the body. This is the important thing, that if you see this decrease in insulin, because in type 1 there is already they are insulin deficient. Again in type 1 that increase in glucagon is lost. So two defense mechanism, decrease in insulin, increase in glucagon is lost. Third is the increase in epinephrine is often attenuated. That is, there is increase, but that increase is not as required in hypoglycemic phase, and increase in the neurogenic symptoms that often is attenuated. So in type 1 patients, this counter-regulatory mechanism is defective, or that is not, does not work properly. So this is the reason we know a type 1 when there occurs the risk of hypoglycemia is significantly high, and the hypoglycemic on awareness is also significantly high in those group of patients. So what is happening in the different types? If you see, take a non-diabetic patient, during hypoglycemia, the insulin decreases, glucagon increases, adrenaline increases. In type 1 diabetes, there is no increase in insulin, no increase in glucagon, and the epinephrine effect is attenuated. Early type 2, it is like similar non-diabetic, that is insulin decreases, glucagon increases, and epinephrine increases, but when it is late type 2, probably it behaves like a type 1. That means already there is all the beta cells is exhausted, so there will be no insulin production. The rise in glucagon will not be there, and again the epinephrine effect is be attenuated. So late a type 2 diabetic after 15-20 years, or a type 1 diabetic, they behaves like similar, particularly during the phase of hypoglycemia. So let us come to what is HAP, hypoglycemia associated autonomic failure. It's a reversible attenuation of sympathoadrenal symptoms of hypoglycemia. That is what we have discussed during hypoglycemia, the epinephrine increases. This increase in epinephrine is responsible for augmentation of the blood glucose and reduction of symptoms, but here it is not happening. So there is occurs a reversible attenuation of sympathoadrenal response to hypoglycemia due to recurrent hypoglycemia in the current past. There are two things happens. One is there occurs a defective glucose counter-regulation. That means this increase in insulin, increase in glucagon, decrease in insulin, increase in noradrenaline does not happen. Third is, second part is hypoglycemic on awareness. That means when there occurs a frequent hypoglycemia in the recent past, the patient reduces neuroglycogenic symptoms and neurogenic symptoms comes down. So this is leads to hypoglycemic on awareness, and this phenomena is result in a shift in the glycemic threshold. That means suppose in the normally we have discussed about the threshold that by 70 patient will start developing hypoglycemic symptoms. At around 60 to 65 glucagon increases, but if someone has a recurrent hypoglycemia, probably this threshold comes down, and unless until patient does not reach 30-40, probably these symptoms will not happen. So there occurs a gradual reduction in the threshold of the blood glucose to produce, because the body behaves as if a normal blood glucose 60-70, if there is recurrent hypoglycemia, body behaves as if the 60-70 is normal for the body. So there will be no reduction. So this hypoglycemic associated autonomic failure in early type 2 diabetes, that is relatively preserved. Insulin increases, during hypoglycemia, insulin increases, insulin decreases, glucagon increases, and adrenaline particularly increases. But in the advanced type 2 and type 1 diabetes, or relatively mildly moderate insulinopenia, that leads to actually no further increase in glucagon, or no further, there is no insulin reduction will be there, because already it is patient is insulinopenic. So due to this, actually this adrenomedullary epinephrine response comes down, sympathoneural response comes down. that occurs defective glucose counter regulation, also impaired awareness to hypoglycemia, that leads to actually recurrent hypoglycemia in those group of patients. So let us see what is the evidence is telling how the body behaves. If you see, this is a study in the hyperinsulinemic hypoglycemic clamp study, where actually if you want to see that before, suppose someone develops hypoglycemia, what is happening to next day. You see the glucose, it is almost same. Glucose is almost what the body behaves, glucose is coming down. You see the insulin again, in particularly during the phase of hypoglycemia and also normoglycemia, it is also similar. But you see the epinephrine level. After hyperglycemia, you see the right side, after hypoglycemia, the epinephrine is in the hyperglycemia, it is significantly high. But following a after hypoglycemia, the white one, you see that is significantly reduced. So the epinephrine response is significantly reduced if someone develops recurrent hypoglycemia. The blood glucose is same, the insulin level is same, the glucagon level is same, but the epinephrine response comes down after even if a single episode of hypoglycemia. Again, if you see the total symptoms, neurogenic symptoms and neuroglycopenic symptoms, again, you see the upper panel, the neurogenic and neuroglycopenic symptoms after hypoglycemia, again, it is coming down or significantly less. So that means if someone develops recurrent hypoglycemia, the adrenaline or epinephrine response comes down, and there will be no adequate increase in the epinephrine. So this neurogenic and neuroglycopenic symptoms significantly comes down. So what are the risk factors? For hypoglycemia associated autonomic failure, if you will see that is absolute endogenous insulin deficiency, if someone is having history of severe hypoglycemia or impaired hypoglycemic awareness or both, or a recent antecedent hypoglycemia or severe exercise or during sleep, or a aggressive glucose glycemic therapy to lower the HbA1c, to lower the glycemic goal. So these are the certain risk factors which can lead to hypoglycemia associated autonomic failure. So what are the mediators? These are the sleep, opioids, exercise and serum cortisol. These are some of the mediators which has been actually found to be associated with HAP. And this is the thing that they have compared. The A is actually during awakening phase, B is the during sleep phase. So what is happening to the particularly the epinephrine level during the awakening phase, you see there is significant rise, but during sleep the epinephrine is the B, you see the B graph which is significantly reduced. Sorry. So same thing, you see what is happening to particularly the norepinephrine level, same thing happening. In the A, you see during the awakening phase it is significantly high, but you see the B, that is actually it is significantly blunted. So during the sleep, the body response of release of epinephrine and norepinephrine also significantly less in comparison to the awakening phase. So this is one of the reasons why particularly during sleep the number of hypoglycemic events increases, or hypoglycemic associated autonomic failure is quite significantly associated with sleep. Again, the opioids, it has been found that during this, those who have having hypoglycemic associated autonomic failure, or during hypoglycemia, the opioid level is significantly increases in the body. So they try to give the opioid receptor antagonist naloxone, naltrexone. What is happening? They have seen that use of naloxone causes increase in the particularly sympathetic adrenal response to hypoglycemia, also prevents HAP. That means those who are having particularly HAP, probably one of the treatment modalities is naloxone, which can significantly reduce the HAP. Hence, it is one of the potential therapeutic function for particularly opioid receptor thing. Again, during exercise, usually opioid beta endorphin really significantly increases or significantly increases the sympathoadrenal response. So when a healthy individual do a vigorous exercise, this elevated endorphin reduces catecholamine release, or subsequently following exercise, the risk of hypoglycemia or response of hypoglycemia to particularly this adrenaline comes down. So following a vigorous exercise, if you are doing probably subsequently, the risk of response to hypoglycemia significantly comes down. So doing a vigorous exercise, we should be very much careful, particularly in type 1 and type 2 diabetic patients. Again, this hypoglycemia associated with elevation of the corticosteroid level is significant found. But again, CRH hormone plays a critical role for this impaired counter-regulatory part during hypoglycemia. But still, actually, they did not get an actual pathophysiology or actual way how this hypoglycemia is being counter-regulated by this cortisol is actually not well studied or well found in this mechanism. Then what are the mechanisms? The brain glucose metabolism hypothesis, brain glycogen supercomposition hypothesis, brain fuel hypothesis, and brain neuronal communication hypothesis. There are 4 hypotheses are there for particularly HAP. These are the, when there occurs hypoglycemia, first thing occurs, there occurs decrease in the energy depletion, also there occurs a metabolic stress. Due to this energy depletion and metabolic stress, 2 things will happen. Either there will be cell death or cell will adapt itself to have the conserve energy. So if there is cell adoption occurs, there occurs alternate fuel, altered glucose metabolism, and also that ultimately leads to what happened in this decreased energy depletion and decreased metabolic stress. When there occurs a subsequent hypoglycemia, probably it can actually, this cell can sustain itself because by conserving energy. So this is adaptive or preconditioning by which actually cell death does not happen. But during this, if there occurs a energy depletion and decreased metabolic stress, that leads to decreased sympathetic activation, that leads to hypoglycemic unawareness and also decreased adrenomedullary response, and probably that plays a critical role for the HAP. So this is what we can tell, this is a maladaptive function of the body, or during this adoption to conserve or to preserve the cell, this is the HAP happens, or this hypoglycemia associated autonomic failure happens. So these are the certain particularly brain areas which actually acts this orbital prefrontal cortex, medial prefrontal cortex, they act on the hypothalamus, and this hypothalamus, this decreased attenuated increased sympathetic activity, that is decreased insulin, no increase in glucagon, all those things actually acts on the pancreatic beta cells to actually plays a critical role for particularly the hypoglycemia associated autonomic failure. And what are the consequences if someone develops? Probably there occurs severe hypoglycemia, poor cardiovascular outcome, the cognitive and intellectual function comes down, there occurs dementia, there occurs psychological consequences, the quality of life comes down, and again the economic burden significantly increases for the HAP. And this severe hypoglycemia, then hypoglycemic unawareness, we'll discuss about something that of course almost 40% in the type 1 diabetic patients, and we know that hypoglycemia unawareness increases the risk of severe hypoglycemia almost 17 times in type 1 diabetes and 6 times in type 2 diabetic patients. And those who are having impaired counter-regulatory hormone, they are further increase the risk of hypoglycemic unawareness in the range of up to 25 times. So you can imagine that this hypoglycemic unawareness is one of the significant factor which plays a critical role for defective glucose metabolism and defective glucagon response during phase of hypoglycemia. So again, there is a study which try to see during acute hypoglycemia, what is happening to the endothelial function. Here they have taken 2 things. The first one is a person having normal glucose. The second one is after next day, if patient develops hypoglycemia. And the third one is first day patient develop hypoglycemia, and the fourth one is second day again develop hypoglycemia. So 4 things. If someone is the left side of the panel, that is what is happening to the endogenous nitric oxide mediated vasodilation. In the day of euglycemia, it is normal. But as the patient starts developing hypoglycemia, you see there is a significant reduction in the nitric oxide mediated vasodilation. That leads to endothelial dysfunction. In the second part, you see that if you are giving exogenous nitric oxide, watching whether nitric oxide vasodilation causing vasodilation or not, you see in the normal person or euglycemic phase, it is normal. On the day of hypoglycemia, third one, it is almost similar with that, because on the day you might not get, but in the subsequent day, if developing hypoglycemia, probably it further significantly reduces vasodilation. So a first episode of hypoglycemia might not produce significant vasodilation, but if someone is having repeated hypoglycemia, that leads to significant increase in the risk of endothelial dysfunction, and that is one of the critical factors which leads to complications in the diabetes. Again, they try to see what is happening to baroreflex sensitivity. You see during hypoglycemia, it is significantly coming, and norepinephrine and epinephrine level, again during hypoglycemia, recurrent hypoglycemia, it is significantly coming. And so when someone is planning a rigorous glycemic control, these are some of the things which does happen, or you have to critically think about these things during the rigorous blood glucose control. So this is a meta-analysis they try to see. It's from the International Hypoglycemia Study Group. They try to see during that severe versus no severe hypoglycemia, what is happening to the major cardiovascular events, major microvascular events, death from any cause, cardiovascular cause and non-cardiovascular cause, everything all actually prepares. Yeah, 1 minute. So everything all is actually towards severe hypoglycemia in comparison to the second part. Again, the hypoglycemia associated autonomic failure, whether it is a maladaptive or adaptive function. So we see that if someone is having a maladaptive from the heart, there are certain maladaptive response, like there occurs increased risk of hypoglycemia, arrhythmic death, and also atherosclerotic vascular disease. And once someone is having a recurrent HAP, probably subsequently a adoption does happen in the body, so arrhythmia-induced death is significantly reduced in those group of patients. So prevention and management is utmost important. You should acknowledge the problem, and aggressive glycemic therapy is not allowed. You should go for, particularly nowadays, we can have time in range profile we can make. From that, you can clearly do frequent SMBG and CGMS, use TIR, so that at least you can detect hypoglycemia and try to prevent hypoglycemia in those group of patients. And this is the individualized target. We know everybody, those who are having risk, those who are having microvascular complications, any sort of terminal ill, probably don't try to do or don't try to control the blood glucose tightly in those group of patients. And this is for type 1 and type 2. The target is always keep the hypoglycemic range in type 1 and type 2 of prolonged range. It should be less than 5% hypoglycemia. If someone is having a newly detected type 2, probably hypoglycemia should be up to 5% is allowed, more than that is not allowed. And treatment is optimizing the insulin. There are certain pharmacological therapy like beta-adrenals, like methylxanthine therapies, and other like islet transplants and fructose. Just another 1 minute. Fructose are there, so that you should optimize the OAD and insulin, like newer basal insulins, rapid-acting insulins, the risk of hypoglycemia will be less. And you should go for continuous insulin infusion. We have actually shown that if someone is having CSII, that actually significantly reduces the risk of hypoglycemia. Here in this study, actually from 1.25 it reduced to 0.05, the risk of hypoglycemia. So that is one of the important thing. Another important thing is islet cell transplant. That islet cell transplant, actually both it produces insulin and glucagon. Again, due to this glucagon response, the risk of hypoglycemia is significantly less. It has been actually pre-post, you say 87%, from 87% it has reduced to 13%. And some of the like beta agonists and methylxanthines are actually, has been actually used for particularly to reduce the HAP or reduce the hypoglycemic risk, particularly asthma. So concluding my talk, the reversibly attenuated sympathoadrenal response to hypoglycemia due to recent or iatrogenic hypoglycemia is one of the important factors. Mostly occurs in type 1 diabetes, also in advanced type 2 diabetic patients. There are many experimental agents that can be tried and studied, but the goal is complete avoidance of hypoglycemia for 2 to 3 weeks. That can actually take care, or the risk of hypoglycemic unawareness will be significantly reduced with that much. Thank you.
Well, thank you, Malak. And thank you, Rajesh, for this kind of introduction. And I appreciate Dr. Sharma. Thank you very much for this program. Thank you. And how are you? It's been a pleasure to have you. And thank you, entire India team, including Bansi. I appreciate presence of Suprati, Amit, Abhay, and all of you. Those who have spent their afternoons, Saturday afternoons in Goa, you can imagine. And such a beautiful property all around. All around. It's very tough. But what I have done today is, I asked a favor from Dr. Sharma because I had a flight to catch back. And he was generous enough to allow me this session a little early.
Little off track. So Pratik was not very happy. He had some different plans for our session. But probably you can all ask difficult question to Supratik because he's all around here. And let's talk about the genuine question that has been always asked. when we talk about the newer drugs available in the cardiovascular armamentarium that we have for, especially when the management of diabetes comes, is the cardiorenal panacea addressed with the latest drugs. So let's talk a bit about it. It's been amazing, isn't it, that how generous and how aggressive European Society of Cardiology was, and everybody appreciated their way of interpreting the whole management of diabetes and associated risk factors. And it was this in 2019 which actually caused a sensation in not only in the endocrine world, but in the cardiovascular people world, the cardiologist world, the nephrologist world, where they clearly came out and challenged the place of metformin as a first drug, even in the drug-naive patient. And they came out very clearly saying that when the patient is very high risk for an atherosclerotic cardiovascular disease, or the patient has got a high chances of developing a cardiovascular event or a renal event, in a drug-naive patient, you may consider either SGLTs or GLP-1 receptor agonists as the treatment of choice. And if the patient is on with metformin already, then there is no reason why you should be stopping the patients. And I'm going to talk to you about the same thing in continuation. A question which is asked usually, which is also now probably little bit addressed, not completely. American Diabetes Association 2022 still is little conservative as far as the choice of the therapy at the initiation is concerned. They still want to stick to metformin. But then what is most important is that they have now clearly come out again with the same echoing of the the European Society of Cardiology guidelines, saying that if the patient has got a higher risk for an atherosclerotic cardiovascular disease or a heart failure or a kidney injury, initiate these patients with either the SGLT or the GLP-1 receptor agonist. So the question is renal cardiometabolic disorder is a panacea available now? Friends, I am Dr. Mangesh Tivaskar. We all know that heart and kidneys, as Arvind has beautifully alluded to it, they are absolutely hand in glove. Something goes wrong to the heart, kidneys are going to shout out. Kidneys are unhappy, there is going to be a challenge. And majority of the times you all must have witnessed that, especially in the patients, those who are on with the hemodialysis or a renal replacement therapy at the end stage renal disease, majority of the patient, nearly 50% crowd, they do not even reach the stage of dialysis, they develop a cardiovascular event and we lose them. So that is the intent, and the connect is very intense. And the organ dysfunction, no matter it can be the systemic effects or the sympathetic effects or the inflammation or the endothelial dysfunction or the oxidative stress or excessive fibrosis, but these two concomitant disorders are the highest reasons for the mortality associated with diabetes and the metabolic challenges, and we all are aware about it. And we all love evidence-based, right? We all of us love evidence-based. And we always talked about the importance of statins, BP-lowering medications, especially beta blockers, metformin, ARBs, ASS. But then, in last 5 years or so, we are blessed with these two agents, GLP-1 receptor agonists and SGLT2 inhibitors, to manage the cardiorenal risk continuum, which is the cause of concern. So let's first look at SGLT2 inhibitors, and we all are 100% convinced about their efficacy, their ability. If you really put in all the SGLT landmark trials together, no matter it could be all-cause mortality, a cardiovascular death, a 3-point MACE, or a renal continuum, you will see that SGLTs did a magnificent job. It was for the first time any trial in the cardiovascular basket has proved the superiority as far as the outcomes are concerned. And we were very happy. Not only we were happy, we were stunned, we were mesmerized. We were not very sure what is happening. And what is most wonderful thing about these drugs was that the benefits were very, very quick. As quick as 15 days, DAPA heart failure showed 15 days benefit. So the Kaplan-Meier starts separating technically between 10 to 15 days. Tell me which drug does that? Now that is the place where SGLTs have scored probably over the other group of the drugs. And surprisingly, if you really look at the other glucose lowering therapies, they did not, even though they had a great glucose lowering ability, but they never had this superiority benefits or the outcome driven, I would say, benefits. And these are all the explanations which are given by most of the world. But I'm going to tell you about some newer nuances of SGLTs. Now, this is what the SGLTs are doing differently apart from the regular effects that they are thought about. No matter, it could be the effect on the renal hypoxia by addressing the sodium hydrogen exchanger forms, NHE3 forms, where it reduces down the sodium, the renal hypoxia. It can be adipokines and the reduction in the inflammation. It could be the epicardial fat. It could be the different way of handling the ketogenesis and the small ketone energy fuel mechanisms. So myocardial energetics is different. The lipid handling is different. Inflammation is different. Reduction in the volume is different. And this has been proved by, this is a beautiful paper by Subodh Verma and team. And this got published in 2018, and we know how different SGLTs are when it comes to the volume loss. They cause volume loss in the right places. And what is the beauty of SGLTs is this, that they do cause the fall in the intravascular volume by reducing down the interstitial fluid congestion, which is the most difficult fluid to treat. A small data from the empagliflozin group, but I am sure that dapagliflozin and to a certain extent Cana also has, that the fluid loss happens, but it is free of electrolytes. So you don't have to be worried about the electrolyte challenges. This is most important. I don't feel so any other group of the drugs have shown this. Look at the pulmonary end diastolic pressure. 2 millimeters drop in the pulmonary end diastolic pressure, and that is the reason why, probably one of the reasons why patients, they are benefited even with the heart failure with the preserved ejection fraction or a mid-range ejection fraction, because this is what is happening. Fuel energetics, I am not going to go into the details about it. Probably Dr. Sundar Mudliar, Subodh Verma beautifully published this paper in various cardiology and the diabetology journals. But they do what? They improve on the glycogen related challenges, the free fatty acid related challenges. Not only that, the fatty acid oxidation goes down. The beautiful thing is this, that glucose oxidation, so glucose starts getting utilized beautifully well, and that is the way it impacts the cardiac fuel energy handling. One of the very interesting data which has again come from the SGLT2 group is this, that not only they do cause the systolic and diastolic blood pressure drop, but also they cause drop in the central aortic pressure, which talks about the improvement in the vascular health, which talks about how it is important to manage arterial stiffness, which is the main culprit. And that is the place where probably empagliflozin, even though this is an empagliflozin driven data, but probably, dapagliflozin also has got a similar data there. Same way, EMPA hemodynamics had shown that in a patient, those who are with preserved ejection fraction, there is a reduction in the end, left ventricular end systolic filling volume. So that's how probably in the preserved ejection fraction the patients are benefited. It changes the entire left ventricular modeling. So left ventricular hypertrophy goes down, the oxidative stress goes down, and not only that, it also causes reduction in the fibrosis markers. Now what are the fibrosis markers that you are looking at? Fibrinonectin, or the smooth muscle proliferating factor. These are all the things which actually are the pre-fibrotic markers, and you can clearly see that the patients on with empagliflozin or dapagliflozin, they beautifully get benefited. SGLTs reduce inflammation, no matter it could be a TNF alpha, an interleukin 6, and you are talking about CRP. Not only that, the adiponectin levels, they go up, leptin levels go down, and the ratio of leptin and adiponectin, which actually talks about the cardiovascular health, it improves a lot. This is what I have already spoken about, the renal stress related hypoxia. So whenever there is an SGLT is on board, the sympathetic nervous, and this is what exactly Dr. Abhay Sahu was talking about, that whenever you are having either hypoglycemia or the related challenges or a cardiovascular challenge, one area which is of a concern is usually the sympathetic nervous system. Now you have a drug which can reduce down the sympathetic tone, and that's how where probably by acting on the sodium hydrogen exchanger form, SGLTs reduce down the arterial stiffness at the kidneys, It reduces down the sympathetic stimulation and will reduce down the incidence of heart failure. So it doesn't just act on the heart, but also beautifully acts on the kidneys. As far as the renal benefits and the arrhythmia benefits are concerned, I'm not going to touch upon this. So these are all the new areas where SGLTs are now also credited for benefiting as far as the cardiovascular outcomes are concerned, or the improved cardiovascular outcomes are concerned, where you are talking about the altered adipokine regulation, you are talking about autophagy, you are talking about the organelle clearance, you are talking about reduction in the oxidative stress, you are talking about the improved cardiovascular ionic homeostasis, and also you are talking about the better handling of the myocardial energetics. Amazing ways of renal benefits. So whenever I talk about SGLTs, I really am mesmerized that how much and how many things these drugs are going to uncover to tell us that yes, these drugs, they deserve a genuine attention. Similarly, if you look at the GLP-1 receptor agonist, almost similar, not as potent as SGLTs as far as these benefits or the evidence base is concerned, but then there are some signals. Look at LEADER, look at SUSTAIN 6, look at the outcome trials, the hazard ratios, the benefits of 3-point MACE, cardiovascular death, non-fatal MI, non-fatal stroke going down significantly. LEADER proved that primary MACE outcomes go down significantly. The cardiovascular death, every 1 in 5 patients are benefited. Apart from that, just not weight loss, but the kidney protection along with the reduced inflammation is a part. If you really look at the SEMA data, now SEMA is now a heartthrob of a lot of people, and especially after oral semaglutide launch. But look at SUSTAIN 6 or PIONEER 6, 24% relative risk reduction. That is significant. Now 24% may not hit you here, but what if I say that every 1 in 5 or 4 patients are benefited? Do you realize the value of these drugs? Liraglutide has beautifully showed that it can have an ability to stop the progression of atherosclerosis. So whenever the patients, they have a progressive atherosclerosis or an established atherosclerotic cardiovascular disease, these are the patients who are likely to be benefited as SGLTs. Along with that, probably GLP-1 receptor agonists in combination are going to really mesmerize all of us. LEADER also showed that the cardiovascular outcomes, they are significantly better in the liraglutide arm, and the renal benefits are also equally significant as the cardiovascular benefits are concerned. LEADER again showed that the primary cardiovascular outcome in the patients of an established chronic kidney disease are also significant and worth taking note of. It reduces down the progression of macroalbuminuria, need for the renal replacement therapy, or the need for the renal transplant. It is amazing, and this is uniform in almost all the SGLT related trials. So finally, friends, if I have to talk about the continuum of the cardiovascular renal panacea, at one arm you have got SGLTs, on the other arm you have got GLP-1 receptor agonist. SGLTs, vascular euphoria, and the GLP-1 receptor agonists are the anti-atherosclerotic, anti-inflammatory effects. Now these two combined will offer you a complete coverage of the cardiovascular renal axis. That is a challenge. So that is exciting perspective for diabetologists, for the primary care people, for the cardiologist, and for the nephrologist. And you will find that these are the only molecules where the cardiologist, endocrinologist, diabetologist, nephrologist, physicians, and even the primary care people sing the same song of appreciation for these two molecules. So finally, friends, how true it is and how important for us to understand. It is our job as clinicians, as doctors, to give them medications to our patients that they should function to stop people dying young. So the people must die young as late as possible. This was a beautiful statement by Ernest Widner. How early? Maybe right at the inception, because if you wait for an event and to start, then probably you are not practicing the evidence-based medicine now. And especially whenever you look at the SGLT trials, especially look at the declaratomy, where they talked about primary prevention so beautifully well. So the question of is cardiorenal metabolic disorder, is panacea achieved now? I would say that this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. Thank you very much for your kind attention. I
Thank
really
you,
appreciate
thank you.
And thank you, Dr. Sharma sir, again for my so much being kind to me. Thank you very much.
Thank you so much, sir, for wonderful and excellent talk as usual. So now I requesting to, if any question, all of the three speakers are here. Please, any question. So, special thanks to
Divakar sir, Professor and Arvind sir for wonderful and excellent talk as usual. And it's our pleasure and honor to listen you, sir. Special thanks to all of